the same in all the three settings of India, UK and USA? Who recognize them?
Usually, I think the suspicion is raised commonly at schools. If you talk to a school teacher, and the teacher, I think, would be able to tell, I think, how different the kid is. And the next thing is going to be, I think, the diagnosis. If it's if the parents take their kid to a pediatrician or a psychiatrist, that's when the diagnosis is going to be made. And in the UK, commonly, it was mainly a treatment was given by psychiatrists predominantly. They used to make the diagnosis. But in the USA, pediatricians are comfortable recognizing and treating things simple ADHD. Usually when it is resistant and things, that's when they come to psychiatrist attention. And because we are talking about a disorder with a fairly simple treatment, and of which 85% and more, I think, usually respond to first-line treatments. So I think it's a disorder that can be easily treated by a pediatrician or a family doctor.
What is the gold standard method of making a diagnosis of ADHD? Are there any rating scales, instruments, any particular assessment tools, anything based on which we can say for sure that this person or this child has ADHD?
Very good question, Raghu, because you said, I think, the parents, they're suspected something is going on, like an ADHD, and then I think, where do we go next? Commonly for ADHD to be diagnosed, it has to be present in two settings. So the kid, I think, the two settings are going to be home and school. Both of them are seeing the same thing. So we commonly use a questionnaire called the Vanderbilt's. The reason I think we use it is because it's a free online tool that you can download the scale, and I send it to school. I give it to parents, then I'll ask them to rate it. Once a kid is hyperactive, common differential is going to be, is the kid depressed or anxious? Those are the other things that you worry about. And you have to rule them out. And this scale, I think, helps you with that. So you get a rating from, you fax a copy to school, speak to the school teacher, get an account of their behaviors, and then I think tell the parents to fill it up. And then I think book a follow-up appointment in a few days' time and go over through the scales. And then I think you're seeing the kid, you're seeing his behavior in your office setting. And then you're going to take things from there. Then you're going to cut off. And the scale is self-explanatory, and you have a rating scale. That is one option. And this is the free option, and it's a Vanderbilt's is a very decent rating tool. The next one I think I used to use when I was in England was Connor's rating scale. And it's a very good scale too, but it is, again, I think it carries a price tag to it. So lately, I think more and more I've been using, I think, Vanderbilt's more than the Connor's. But both of them are good rating scales. If the institution is sponsoring a Connor's, it will be up to individual clinician to make a diagnosis. But the key thing, Raghu, is going to be, I think, look at, because these behaviors start at an early age. So with the previous DSM-4 diagnosis, DSM-4 is a diagnosis criteria that we use in the United States. It used to be 7. Now it has gone up to 12. But any physician is going to have a history that this is the way kid has been for most of his life. But say, I think, if the kid was doing well, did not have these problems until a year ago, they just started, I think, 3 or 4 months ago, then you need to focus on what happened 3 or 4 months ago. That is going to give you a diagnosis. Because anxiety and depression, again, I think usually they have a clear-cut, I think, antecedents. Or you can decipher it based on the history that you get from children and their family. And again, I think the other thing which complicates it is going to be that ADHD kids, again, I think they have more propensity to be depressed and more propensity to have anxiety disorders as well. So as a skill of a clinician, you need to delineate. Oh, it's 60% ADHD, probably 30% anxiety and depression. So I think let me treat the ADHD first. It's 80% anxiety, probably I want to treat the anxiety first. More than I think I focus on the ADHD is probably I'll leave it for, I think, a few weeks down the lane.
Again, summarizing what you have just now said, so what you have said is that there are some rating tools, some free ones, some paid ones, which the individual practitioner can use and make a diagnosis. But if a clinical history is taken, then that is also quite useful to make a diagnosis, is what you have just said. You have also just said that depression and anxiety can also cause problems similar to these ones. So the practitioner needs to be aware of these as other reasons, other psychiatric reasons why a kid could be having these kind of behaviors. So we need to eliminate them. But you have also said that anxiety and depression could also be because of the ADHD. So the practitioner should be aware of this. So it is skill of the practitioner in taking a psychiatric history, a detailed psychiatric history, which shows that the kid has been having problems in attention or in a restlessness or hyperactivity behavior or in impulsive behavior in two settings, either at school and home or any other two settings, that you can make a diagnosis of ADHD. So, okay, perfect. Now, let's go on to treatment, Venkat.
Yeah.
I would like to know, I know that usually we will straight away, being psychiatrists, we will straight away go to medicines first. But let me go down the less traveled route. Let us go down the route of non-medicine treatment for ADHD. So if you can explain if there are any non-medical or medicinal treatments for ADHD and if they have any evidence. So if you can let us and our viewers know about any non-medicine part of the therapy, and then we can come back to medicinal part of the therapy, because I know medicines or drugs is one of the important things that we use in ADHD. So first let us start with the therapy part or whatever is a non-medicinal part, and then we'll come back to the medicines, if that is okay with you.
Yeah, I think that's absolutely fine, Raghu. And you bring up an important point, because treatment of any person is not completely done by medication. Usually, I think there should be some degree of therapy involved. So we'll talk about the evidence part of each bit a bit later when we're talking about medication. But with regards to therapy that you're talking about, we need to look at, I think, what are the reasons this kid is having problems. For example, if it is bad behaviors, which are being, I think, exacerbated by ADHD. For example, the kid can't wait. I think once he goes to a shop, he's going to pull down all the candy jars. He's going to pull down all the chocolate and he's going to eat it. And it is going to cause a lot of embarrassment to parents, and it's not a good behavior either. So what to do in those settings? So one aspect that works fairly well is a sticker chart, or as simple as, I think, a reward management system, whereby I think a kid has good behavior and he's going to get a sticker. And he's going to have a sticker board in front of him that is going to remind him, I think, several times a day that if he is good, he's going to be, I think, he's going to get a reward. Something could be, I think, as basic as that. Again, I think children with ADHD have a hard time falling asleep. So, for example, I think having a sleep ritual or a sleep initiative, something around that time, that could make things, I think, a bit better for these children. And there are things like this that I think we can work upon. And over, there has been, I think, an increase in therapies looking at educational strategies, whereby I think these kids can be helped to focus. And the evidence at best is if they're used as adjunctive therapies. Because as a first-line therapy, the evidence is a bit mixed, but there is nothing that should stop clinicians from prescribing both therapy and medication together. And there are some times, I think, you cannot use medications. So those are the times, I think, you need to focus on therapy. Yeah, but best, I think, used in conjunction.
If my child was having ADHD, would you, as my friend, advise me to go to CBT, that is cognitive behavioral therapy, or parental skills training, or social skills training on its own, or any other kind of therapy on its own without the use of medication? Would you, as a child and adolescent psychiatrist, advise me to use any kind of therapy on its own for my kid with ADHD? That is what I want to know, if my kid had ADHD.
This is what I think I would tell you, Raghu. If any of, I would tell you, medication works the best. And why do you want to go with something that is second line? And also I would say go for the best, and also go through the parental training or the CBT if you want a good adjunct, because you want the best things for your child. And probably doing two things together is not going to hurt. But if you want to pick one, I would advise you to pick medication, because it has a lot more evidence. So 80% success rates, I think, are hard to come by with therapy. But with medication, I think they do.
So what you are telling me, if you were going to advise one of your closest relatives or anybody, that is, if you are personally feeling the pinch of what is happening to one of the kids, you would still go with the medication route if you had to stick to one therapy, or if you had to use more therapies, you would definitely include medication as one of the most important therapy route, and on top of it add any other kind of therapy. This is what you would definitely do, even if it is a personal situation. This is what you are telling me. Am I understanding it right?
Absolutely, Raghu. I think if it's a personal situation or a patient with a straightforward diagnosis of ADHD, stimulant medications are the first line.
So now we come to the most important thing with regards to treatment of a child with ADHD. I understand we doctors are very fond of talking a lot about evidence, and I know that if we keep on talking about evidence behind medicines for ADHD, we'll be sitting here days on end. Okay, I know about that. So let us suffice to say that you, as a child and adolescent psychiatrist, are saying that medicines carry about 85% response rate. So let that be a statement of evidence. We are not talking to academicians, so let's not go deep into the evidence base. But I want you to tell me, and thereby my viewers, what are the medications in general terms that you would want to use, and how long would you want us to use for our children with ADHD, so that they can get the best out of the medication?
The first thing is going to be, you start a stimulant medication usually in a small dose. Okay. The main treatments are going to be, let me put it this way, let me rephrase it. So the medications are going to be stimulant medications are one medication which are commonly used. The second class of medication, they come into a big category called the alpha agonists. And the third category of medications would be a non-stimulant medications, like for example, atomoxetine. So let me tell you briefly a bit about each. The stimulant medications, they are the medications that increase the chemical called dopamine in the brain. You can see it this way. I think the more dopamine, I think the better the attention process is going to be. And the problem is going to be, I think, too much dopamine. Sometimes I think bad things do happen, like people tend to hallucinate and they get a bit high. So with kids, I think you're going to start at a small dose, obviously. Often, I think there are guidelines basing upon their weight regarding the dose that you want to start them upon and the maximum dose that you can go up to. You start at a small dose and you can titrate the dose basing upon response gradually. And because there's a stimulating medication, but still, I think a hyperactive kid on this stimulating medication looks very calm. surprisingly, he has more time to look at things. That is again going to be an indicator that you got the diagnosis right and you're going on the right track. Once you reach the right dose of medication, one thing is unique to kids is they grow. So they're going to put on more body weight, I think, as they go along. And then I think you might have to increase, and they're going to metabolize the medication faster. So you might have to go up on the medication as we go along. And so that's going to be the first line. And that's what most kids would need. Yeah. And again, I think as they go along, I think sometimes some kids do grow out of ADHD. The common thing that they grow out of is going to be hyperactivity. Sometimes I think what I would recommend patients to do would be, in such a situation, is I think during a summer break, when they don't have to focus as much, check out how things are. Don't give your kid a medication for a couple of weeks. And give me a call and let me know how it goes. If it is going well, I might actually in the future gradually reduce the medication and see how things go. Again, that is something I need to weigh very carefully. Say I think there's a big academic test coming up. Say the kid is preparing for a pre-medical exam and there's a quite lot at stake. Probably I will avoid doing that until the exam is over. So to answer your question, I think you treat it with these medications, but I think you have an option of titrating them down. But most people with ADHD, they have these problems lifelong. So you might want to continue these medications for a longer time. Yeah, that's with the stimulant medication. But there are few things you need to keep in mind. So we talked briefly about anxiety being a major problem, sometimes by itself or with ADHD. Sometimes these stimulant medications can make this anxiety a bit worse. So you need to carefully monitor for those things too. And with them being stimulant medication, sometimes they are not, they can be abused by people who are vulnerable. To say, I think, say sometimes there is a market for these medications among the substance using population or the drug addicts. So they might use these medications and they might like it a bit more. So you have to be careful regarding what your choice of medication is going to be in these populations. But it is a bit unusual in most of the settings that we work in, but occasionally I think we find people we should be a bit more careful about so that we are not making their problems worse that they already have. Yeah, that's going to be, I think, with the stimulant medication. And sometimes, even with the stimulant medication at the appropriate doses, some kids continue to have problems. Stimulant medications, we talked, they work on a chemical called dopamine. So next chemical which is stimulating is going to be adrenaline. And we have alpha agonists that make some changes in the brain. So increasingly they're getting used. So those are the medications I think we can use as the next line. In some situations, I think these stimulant medications can make anxiety worse. So in those situations when the stimulants are making anxiety worse, we can use a third class of medications like atomoxetine or Strattera. So we have a variety of options that you could tailor for the kids, basically.